Okay, I'm gonna come up here and just stall for about 30 seconds as people gather to their seats. I feel like our room had kind of filled up a little bit, more so in the last 30 minutes or so. So we have a little bit over 200 people physically in this room right now. But did you know we have over 300 people watching us right now via Zoom? So hello to everybody who's on Zoom. And welcome for those of you who just joined us just now. I ask everybody just to imagine that you're in a beautiful cabin in the woods, obviously. Look at the architecture. It's perfect weather outside. The fire's crackling. In this intimate setting, we're going to learn, teach, question, and most importantly, think through this complex landscape of AI to understand how we collectively can reach our common goal to advance human health. For our next keynote, Role of AI in Modern Medicine, Modern Bedside in Healthcare, I'd like to invite Dr. Nigam Shah to the stand. Dr. Nigam Shah is a professor of medicine at Stanford University and the chief data scientist at Stanford Healthcare. A prolific inventor and author of over 300 scientific articles, he has been recognized for his contributions to medical informatics and clinical investigation. Welcome.
All right, so I'm going to do this without slides because I imagine all of you are people who like to think because you're at the Think conference. And so I'm going to make you think. And you will need some writing equipment in front of you. A paper and pen or pencil is ideal. Electronic can work, not as great. And I know the bags you were given have little pads along with a pen as well, so very little excuse not to have it on you. And while you're pulling that out, I'd like to share where I'm coming from. So I'm a professor in medicine in the Department of Internal Medicine in a division called Biomedical Informatics. And half of my time is spent with students, writing papers, grants, research, one infinite loop. And the other half of me works in the health system as the chief data scientist. It's a role in the IT department supported by the CEO's office. And there the goal is to bring AI into clinical use safely, ethically, and cost-effectively. And I say all three: safe, ethical, cost-effective. And some of the questions that were coming up were quite interesting and all on point, is that we actually have not figured this one out. There's a lot of bullshit going on right now. Like, that's the only word I can use as a professor to describe it. Like, utter nonsense being peddled in the name of AI. And so during the conversation, I will provoke you a little bit. And the reason for that is to get you to think. I'm not trying to offend anybody, but I've found that when you are faced with information that creates some cognitive dissonance, it engages your critical thinking, and that's what I'm going to try and do. All right, so let's dive in. So first, I want you to imagine in that piece of paper that you might have in front of you, put it in landscape mode, and draw an arrow of time going left to right at the top. And on that arrow of time, put in a few circles. These are medical events that have happened to this particular individual whose timeline we're drawing. And this could be a loved one, it could be yourself, it could be a patient you've treated, it could be a case report you've read, doesn't matter. I'm not going to ask you about it. Imagine a 5-year journey. You should have 3 to 4 events that you've imagined in that person's timeline per year as you draw out that timeline. How many of you are clinicians in the audience? A good chunk. What I find with clinician audiences, for the most part, is they have trouble imagining a timeline and they have trouble imagining events outside their specialty. So a cardiologist will gladly put in a heart attack, an AFib diagnosis, and maybe reduce cardiac output, but they will not think of the pneumonia, their COVID infection, or the skiing accident that the person might have, or the eye problems they have, or the retinal detachment because of their diabetes and whatnot. That's somebody else's problem. Keep filling out the timeline. I'm just giving commentary. We're going to use that timeline because without that, it's not going to make any sense. There's 123 fellowship and residency programs just on our campus. About 26 clinical departments. US-wide, there's 184 professional medical societies, about 13 or so just in cardiovascular. It's ridiculous. Like, I'm waiting for the time when we have the left-hand surgeon separate from the right-hand surgeon. We're almost there. Like, we have experts that will do the neck, but not the shoulder, and do the shoulder, but not the neck. That's not how humans experience healthcare. It's the same body, the same person. All right, so now that hopefully you've had a few events laid down on that timeline. Now, on the left side of your page, the non-portrait side of the page, I want you to imagine the data that would have been generated when that particular encounter happened. We might create ICD CPT codes because everybody likes to get paid. We might create problem lists, history of present illness. We might have a treatment plan, a medication order, a lab test order, an imaging order. Every hole in the body, we can send a camera up and take a short video or a picture. We can measure electrical signals in 7 or 8 different places. EKGs, EEGs, EMGs, esophagus, multiple, wherever we can touch an electrode, we can measure a signal, right? We can do gait analysis. Like, most people, again, the clinicians can immediately come up with the 5-10 things their specialty does. But anything outside their specialty, they have trouble with. If you think about it across the entirety of the medical profession, we produce data on probably 500 modalities. Genetic sequence, proteomic analysis, metabolite measurements, antibody measurements, biopsies, histopathology stains, radiomics, like you name it. I can keep going. And the reason what I'm trying to do, I want you to go outside of your comfort zone. Imagine this massive amount of data is possible to generate. So now if you've been with me and diligently done the homework that I've been giving you, and I would expect only a third of you have done that, you would have a timeline going from here all the way to the other side here. Like, imagine an arrow on top of my head, has some events on it. I'm drawing my slide, by the way. And then the photographer is like, what is this guy doing running around? And then here we have the ICD codes, CPT codes, images, lab tests, medication orders, and that list goes on, okay? So we have 5 years. Let's say we have 500 items. And then when we think about where all this data are, we say the word EHR. The EHR is one of 1,500 IT systems that a healthcare enterprise runs. So this thing, let's give it a name, because you're imagining it. You got to get a name, easy to refer to it. Patient timeline object. No clinician has ever seen an entire patient timeline object. It is only the patient that has experienced the entire thing in bits and pieces along the way. There is no IT staff that has materialized this patient timeline object. It is scattered across multiple IT systems, multiple data catalogs, VNAs and chronicles and this and that. The other two things that are true about this is that there is no single point in time where we've collected all 500 modalities, because that's not how healthcare works. We collect a few things when we need them. And then for any given modality, there is nobody that has a full 5-year coverage, not even the patient, because you might change providers, you might change insurance, and so on. So we have this really patchy, Swiss cheese-like. Actually, if Swiss cheese had this many holes, we wouldn't buy it. This patient timeline object on which we build models. Okay? So we have this thing, this arrow of time, all of these 500 things, and then we have that on 1 person, 2 person, 3 person, millions of patients. And then we squash it all into a nice matrix and train a model. Now, the model could be something as simple as a logistic regression, a random forest, or could be something as fancy as a digital twin. In the end, it's still a model. Now, that model, given a new patient's timeline, helps you do three things and three things only. It helps you classify what does the patient have, aka diagnosis. It helps you predict what does the patient will have in the future. And it helps you make recommendations of what should you do given the classification prediction that has been made. Those are the only three things models do. Now, in general language, we might abuse this conceptual notion quite a bit and say things like, oh, I did some analysis and I predict in this image there's pneumonia. That's not a prediction. The pneumonia is already there. You just figured it out. That's the very definition of diagnosis. There is no such thing as predicting sepsis. An absolute nonsensical sentence to say, I have a sepsis predictor. Because every sepsis predictor, what it does is it tells you the patient has sepsis and you have not yet figured it out. That is the very definition of classification, what the patient has, aka diagnosis. Prediction is you tell me somebody who's going to die in 3 years or 5 years or 10 years, or they're going to become expensive in 3 to 5 years, or they're going to develop AFib, but they don't have it yet today. Then it is prediction. I tell you tomorrow's temperature, that's prediction. I tell you it's hot, it's not prediction. And then treatment recommendation requires causal inference. You need integrity in terms of being able to reason about counterfactuals. Doesn't always work. A lot of times people are just finding some association then saying that's a treatment recommendations. So those are the three things we do with models. Then it's helpful to think, what do we do those things for? So we do those things, classification, prediction, recommendation. So again, if you still have that piece of paper, I want you to draw a little table with 3 rows and 3 columns. The 3 rows are classification, prediction, recommendation. The 3 columns are science, practice, and business. Because we can do classification, prediction, or recommendation to advance the science of medicine, which is what a school of medicine and academic medical center typically focuses on. That's why we get promotions and papers and tenure. And the pinnacle of achievement is like publish in Nature Science Cell and perhaps get the Nobel Prize. The middle column is about the practice of medicine, where we want to treat patients as they come to us. There's an element of customer service. There's an element of human connection and empathy. And after practice comes the delivery or the business, which is offering this capability to a large population at scale and, like it or not, sustainably or profitably. Because you can't do it if you're always losing money. So I'll give you a concrete example just to hit this one home. There's this condition called heart failure with preserved ejection fraction. I love making fun of it because I'll prank somebody saying, what's the definition of heart failure? And they say, oh, the heart's not pumping enough. What's the definition of ejection fraction? The heart's pumping enough. Like, wait a second. But it is a thing people get, and there's a nice biology behind it. So there's a group of researchers at Northwestern who did some elegant analysis and figured out that this thing is actually 3 heterogeneous conditions lumped under similar presentation. They analyzed about 400 variables and lots of people and developed a clustering algorithm that given a new patient's record, it says you're subtype 1, 2, or 3. Subtype 1, you're dead in 2 years. Subtype 3, you're fine for a decade. It's a massive advance in the science of medicine, our understanding of this disease. And medicine progresses this way. Diabetes used to be 1 disease, now it's 2. Maybe type 2 is now 4 diseases. We used to have fever as a disease, now it's a symptom. So that's how things progress. That's an advance in the science. Heart failure with preserved ejection fraction has 3 subtypes. We advance practice if we get 2 more things. I have a test. New patient walks in, I can administer the test. It could be an algorithm, a regression that runs on their record. It could be an image analysis that runs on their ultrasound. It could be a genetic test. It could be a proteomics test. I don't really care. I want a test, I want to spend less than $1, and I want to get a readout in less than 10 minutes. Is it subtype 1, 2, or 3? That's the whole point of a test. But then after the test, I also need a treatment. If I'm still going to treat the subtypes 1, 2, and 3 the exact same way, all we've done is increase the cost of care. Now, let's say we have a treatment as well. That for subtype 1, we can do something more. Subtype 3, we have the permission from the powers that be that write guidelines to not do anything and not get sued. We do that for 5,000 people for 5 years or 10 years, and they live longer or cost less or both. Then we have changed the delivery of medicine or healthcare. And right now, what I see happening is that these magical things called models, which may or may not have even advanced the science, are being presented to us as having changed healthcare. And that is utter nonsense. This is the provocation part. Like, no one's arguing against me. Come on, guys. Yeah.
Or is it regulation? Is it that it's not profitable? But what is why do we not have a ubiquitous, universal patient timeline object?
No, it is a great question, near and dear to my heart. The glib answer would be all of the above. But if we sort of dissect that one a little bit more, individually, pretty much everyone I meet in healthcare is trying to do the right thing. Like, there's very few truly evil people in healthcare. There's a few, like the pharma bro who bought that EpiPen thing and jacked up its price. I mean, there's a few evil people. But by and large, like 99% of people who choose to work in healthcare at about half the price money you can make in consumer tech, they're there to do something right. And so there's a misaligned incentive problem, at least in US healthcare for sure. We only get, as I think our previous speaker was saying, we only get paid for certain things. Now, you might invent the best model to make a prediction about somebody's cost of, or somebody's medical condition, and maybe it costs you $2 to run the model, and maybe if you run the model, you're able to take some preventive action, but if both of them are not covered, you're kind of stuck. So concrete example, we built a classifier to find people who have undiagnosed peripheral artery disease. Because the cardiologists are now starting to think that this condition is missed, we diagnose them too late. If we found them earlier, it would be much better. So the cardiologists are there, they build a model, the vascular surgeon, a faculty member built a model. We take the model, we take it to primary care, they say, well, our guidelines say you should never screen a symptomatic patient. What are you guys doing? And insurance will not even consider payment for a foot ultrasound, ankle brachial index measurement, and so on, unless the patient is symptomatic. So now we're stuck. Like, we have technology, but our incentives and standard operating procedures are misaligned. So there's a big chunk of that. A good chunk is also that a lot of the claims are premature. That these models are not as revolutionary as the headlines claim them to be. Third, incentives in terms of data ownership. So this patient timeline object scattered over 500 systems, if I want to just stitch it together just at my site, that's a lot of labor. And we haven't figured out who should do it, why they should do it, and how will we support it and sustain it. Regulation is often cited, but I think if we figure out a proper way to do this, regulation is not the real problem. Actually, right now, we don't have real regulation of AI in healthcare. It's kind of the Wild West, so to speak. So I would say it's incentives and not having figured out what is it that truly works would be the top two in the list of reasons. All right, so we have about 7 more minutes. Now, this grid that I just laid out, this 3x3, that's probably the most useful thing aside from that timeline. Now, we can take a little tour of the two cells in that grid. The lower row is making recommendations. Middle row is about clinical practice. So a couple of years ago on this campus, we did a project that goes by the name of the Green Button Project. And the idea there was, given a medical question at the bedside, can we produce a 3-page report of what happened to similar patients using millions of other patients this timeline? We did 100 cases at the bedside, at least one from every specialty. Wrote a New England Journal paper and spun out a company. Atropos Health is the name of the company. Now, why on earth would we do that? Even in a well-studied field like cardiology, if I ask you, what fraction of their guidance from their professional societies is backed by level A evidence, the answer is between 18 to 20%. If I ask a practicing physician that if a patient walks in, how often is it the case that they're a direct match to something you have a guideline for? About 20% of the time. So guidelines apply 20% of the time, and 20% of the guidelines are based on level A evidence, so we got level A evidence 4% of the time. This holds true in most fields. So the other times, we're extrapolating. We are using our human judgment to extrapolate or generalize evidence that is not for the situation at hand, and then making our best guess, dutifully recording everything in the EHR, and we never go back. So that was the reason we did the project. Now, when you go back to these kinds of observational data and do a study, it's called an observational study, typically takes 6 to 9 months, and somebody always says confounding, manageable issues from a math standpoint. The hard part is that these studies take 6 to 9 months. How many people from pharma in this room? Zip. Oh, one. Okay. So pharma companies typically spend 50 to 60 million bucks a year buying data, and then will pay consultants about $250,000 to do one study with a turnaround time of 6 to 9 months. We did it in 2 days at the cost of less than 500 bucks. The reason I'm citing these numbers is that if we have such evidence gaps and we're doing things in a manner that's going to cost us 6 to 9 months and $250,000, we just can't afford to do it. So we need a focus on technology that gets the cost of doing business down to a ridiculously low number. In this case, doing an observational study on demand in 48 hours or less for less than 500 bucks. Same thing if we look at the predictive models. If you look at all the guidance that is about how thou shalt build good models, there's about 220 atomic pieces of guidance on how to build a good model. About half of it is about just the model. We have practically nothing on how to design the workflows, how to integrate it in a healthcare system, how to do net benefit analysis. Is it working or not? Not much guidance. And of the guidance we have, if we choose to follow it, building and validating a simple model with 4 variables that works in the ED department to decide patient walks in, do a 12-lead EKG stat, or it can wait. Just that one decision. That model, one of my colleagues, Maya Yidam, did all of this work, takes about 8 to 10 years and $28 million. And then I'm going to use it on about 100 patients here. Cost per prediction is unsustainable, like simply unsustainable. Now, we have all of these healthcare systems saying, oh, we're going to have our own data, we're going to train our own deep neural networks, we're going to do this thing, we're going to build our own models. I was like, okay, your cost per prediction is going to be so darn high that it is unsustainable. So these are the kinds of issues that we really need to talk about. I think our previous speaker talked about this ecosystem play. Unless we solve for the ecosystem and make all of this sustainable, we can have conference after conference, but I mean, it will lead to great tweets and stuff, but we're not going to solve the adoption of AI in healthcare. So I'll stop here and happy to take questions. Yeah.
on your evidence retrieval thing, like, okay, so what kind of data sources, you or your team has been used? Because especially like, okay, the source, I mean, whatever, like, okay, your source you're using it, either from the published articles or like whatever it is. So the validity of like, okay, that source is very, very critical, like, okay, so I wanted to, understand what kind of sources, data sources particularly have used.
Yeah, so depends on the kind of use case. In the Bedside, the green button project that I talked about, we're using our Stanford research data warehouse, so mostly EHR, lab data, medication data, no pictures, and Truven and Optum claims data sets. So again, no pictures. We have prescriptions, lab tests, orders, and results. And in terms of analysis of how valid it is, we can do it in a couple of ways. So a simple one is ask the same question on 3 data sets and see how often you get the same answer. They all have different biases and so on. If all agree, life is good. Like ensembling across sources is like works over and over and over again. Second way to validate is ask a few questions where you know what the right answer is. Ask a few questions where you know that the right answer is no association. Like aspirin associating with left foot fracture, but not with right foot fracture. Like, that's absurd. So ask a few absurd questions, and how often do you say, yep, that's true? So you have an empirical estimate of your false discovery rate. And then the third thing you can do is tweak a whole bunch of these methods choices, the way you're matching, your caliper, this and that. And if the signal is real, those choices not going to matter 80, 90% of the time, you still get the same answer. So that's how you can convince yourself that what you're doing is real. The beauty of all this is it can be automated. So you just put it in a big harness, and every time you get these empirical estimates of uncertainty. Yes. Oh, please.
Oh, yeah. Thank you. So my co-founder and I, we recently had a discussion, right, about like what should we do in the healthcare. And he has a very controversial argument. We should cut down the funding because a lot of innovations are really not really delivering the result we can. So there's something I want to ask, like patients always complain like the healthcare is very expensive, even doctors do, and doctors are underpaid. So where does the money go? And who is actually having this money and how are they spending it?
So one of my goals, which I've not been able to accomplish, is try to have a breakdown of this mythical $4 trillion in healthcare, and where does the money go, right? It would be awesome to know that. We get very conflicting numbers that don't always add up. There are numbers out there that say about 65% of cost is labor. Okay, so that's physicians, nurses, administrators, all of that. There are numbers that say hospitals account for a very large number of the costs, but then there's an intersection. A lot of labor is in the hospital, so we don't have the breakdown. There are numbers out there that say, drugs are only about 300 billion out of the 4 trillion, but the majority of the arguments we see are about overcharging of drugs. So that also doesn't add up. Like, why are we so focused on drugs if they're a very small amount of the $4 trillion? One thing I can say for sure that IT is actually a pretty tiny expense. Tiny, 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 tiny expense. The median IT budget of a hospital is about $8.5 million. Stanford's is much larger. I'm not going to tell you the number. We're not $8 million for sure. But the median's about, let's even say 10, okay? Across all hospitals, the total spend on IT is like $46 to $50 billion total in the whole country out of 4 trillion. So it's a great question as to what is the source of the cost, because if we want to benefit from AI, we do have to figure out a capital allocation plan towards infrastructure, cloud, IT, computer scientists, and so on. And we will have to take it out of elsewhere, otherwise we're going to issue a bond saying of the people whose debts we prevented, it's on their taxes or something like that, right? So I don't know the exact answer to this, but you're absolutely right about the nature of the problem, that across tabulation of the kinds of things people do, labor, durable goods, services, this and that, and where they do it, hospital, insurance, pharmacy, and fill out that grid, super helpful. Yes, there was a question here.
Thank you for the presentation. Amazing.
I didn't show you any
Or, I'm
slides.
sorry. You drew the presentation in my mind and I had to draw it on the piece of paper. With respect to, agree with everything you say, with respect to the patient object timeline and a lot of the pain points that have been mentioned here, one thing I think about is a lot of this pain just because we are in America? Imagine if we were in Denmark, for example, or Taiwan with, single payer, universal healthcare. Do a lot of these problems kind of disappear? Is it just because we're in America?
No, some of them disappear. So for example, incentive misalignment disappears, but other problems surface